I have the pleasure of introducing our guest speaker, Dr. Samia Mora. And Samia is a cardiovascular medicine specialist here at Brigham and Women's Hospital and also associate professor of medicine here at the Harvard Medical School. Dr. Mora received her medical degree from the Harvard Medical School. I think she did her undergraduate training here too. And she completed an internal medicine residency at Mass General Hospital and a cardiovascular fellowship at the Johns Hopkins Hospital. She's a fellow of the American Heart Association, the American College of Cardiology, and the American Society of Echocardiography. She's won a number of distinguished awards. She also serves on the editorial board of JAMA Internal Medicine and Atherosclerosis. Dr. Mora's clinical interests include cardiovascular prevention, women's health, and echocardiography. She's the author of well over 150 peer-reviewed articles, and her research focuses on risk factors and prevention of cardiovascular disease. So for today's presentation, Dr. Mora is going to be talking to us about the health benefits, something very relevant to discussions going on in integrative medicine community of the Mediterranean diet and the results of her really interesting large-scale clinical trial. So without any delay, please join me in welcoming Dr. Mora.
Thank you, Peter. What Peter didn't tell you is that Peter was my TA when I was in Bio 2 at Harvard undergrad. So, so I had a sneak peek at the poll, and usually with these kinds of talks, one is sort of preaching to the, converted already. So about 2/3 of you eat a Mediterranean type diet at least several times a week. So for the 1/3 of you who aren't as much closely adherent to Mediterranean diet, I'll be very happy to share with you the data and also to help for those of you who see patients as well. So Peter, thank you again, and Atura for inviting me. I'll be talking about the Mediterranean diet, focusing mostly on relationships to cardiovascular disease, but also other causes of mortality. These are the top 10 global causes of death in 2000. So you can see ischemic heart disease and stroke were number 1, number 2 of the top 10. This is by the WHO sources. So you may say, well, Samia, this is outdated. It's from 2000, right? But nothing has really changed much. In 2016, ischemic heart disease and stroke are still the number 1, number 2 causes of death. And that's mostly because while we've made a lot of progress in reducing the age-adjusted cardiovascular death rates, the population is growing and it's aging. So we have these 2 factors that are basically increasing the absolute number of causes of death in the US and globally. So here's a question. What fruit? Homer called it the liquid gold. King David posted guards to protect it. Hippocrates called it the great healer, and the Greek athletes covered their bodies with it. I'm sure several, if not many of you. Olives, right. So it's a fruit, right? It's not a vegetable, it's a fruit. It grows on a tree. This is actually from my mom's garden in Lebanon. So this is the Mediterranean diet. This is a schematic of it. It's really more than just a diet. It's not just about food. It's about a way of life. And so I think probably diet is not the right word. It's more maybe, a better word would be maybe cuisine, but that sounds too fancy. So I don't know. It's sort of a lifestyle thing, really. At the bottom of the pyramid here, you can see there's a lot of other things that are healthy habits, such as regular physical activity, adequate rest, conviviality, sort of socialness aspect of not just meals, but other aspects of life. And then on the right side here, biodiversity, seasonality, and I'll talk about some of these actually, as there's a recent Lancet Eat Commission that discussed these in their nice paper. So these are sort of the bottom of the pyramid. And then water and other herbal infusions, sort of tea and coffee are down there as well. Every day, it's really a vegetarian diet, the Mediterranean diet, a lot of fruits and vegetables. In fact, you can't overeat on fruits and vegetables if that's really sort of the base of your pyramid as shown here. In terms of, the fat, the predominant fat is olive oil, in fact, extra virgin olive oil. And there's a lot of competition among people living in countries living in the Mediterranean as who produces the best olive oil, or, so it's really a big thing in the diet. Bread, pasta, rice, or couscous, depending on the country, usually as whole grain components of the food, are also included in the diet. Now, nuts, seeds, and legumes are also very big part of the diet. Dairy is included. It's not, it's not excluded from the diet. So dairy products are included, usually in the form of cheese or yogurt. Often it's the Greek yogurt, what's called the Greek yogurt. It's really more Mediterranean type yogurt that has a lot of live bacteria that are good for the microbiome. And then in terms of the meats, well, it's predominantly white meat, mostly fish and seafood, again, depending on the proximity to the Mediterranean Sea. But also protein from eggs as well is included. And what's really kept to a very minimum is the red meat, in particular processed meats, and these are really at the very top of the pyramid. Potatoes, while they're included, they're also at the top of the pyramid, and sweets, of course, are very low. And wine is in moderation, served typically with the main meals. So that's sort of the schematic of the Mediterranean diet pyramid. Now, this is the map of the Mediterranean Sea, and you can see here there are many countries that border it, but it actually includes 3 continents, Europe at the top, Asia here on the east, and Africa at the bottom. And what's common among these countries, if you've traveled there, is there's a lot of similarities in the cuisine. There are many of the components that I just mentioned. Now, this has been recognized to be a healthy diet for many years. In fact, Ansel Keys, way back several decades ago, there's an annual AHA lecture named after Ansel Keys for his contributions to epidemiology and cardiovascular disease. But he noticed, and his colleagues, that there's a graded risk across countries, in particular going from southern to northern Europe. Even for the same cholesterol. So remember, at that time, cholesterol was just sort of being recognized as a main cardiovascular risk factor. But what he noticed in the 7-country study is that even for the same cholesterol, for example, 200, shown here, you can have a gradation of risk for CHD mortality. And some of that was thought to be due to this Mediterranean diet or other, Mediterranean lifestyle, because you can see here that Northern European countries had higher rates compared to Southern Europe. That's even within the same, region. Now, epidemiologically, this has also been examined in many studies. Initially, it was studied among Mediterranean-type countries. So Trikopoulos' couple, actually, Antonia and the late Dimitrios, have contributed a lot to this. They created a score for the Mediterranean diet because people think, well, the Mediterranean diet now is not very healthy. I go to Mediterranean countries and they're all eating, all kinds of things. And what we're talking about with the true Mediterranean diet is really the diet, sort of very traditional diet, way back in the 50s or even earlier, that in traditional communities people were eating. So it's not really the diet that you're seeing now if you're traveling, although it is influenced by it currently, but it's not exactly the same. So what the Trikopoulos noted was that in Greece itself, when they created this Mediterranean diet score, and this study was published back in 2003, they noticed there are decreased risk for all-cause death, about 25 to 30% reduction in deaths, both from coronary heart disease as well as from cancer. Among the people in Greece who followed more closely a traditional Mediterranean diet, such as the one that was practiced in Crete back in the 1960s and 50s. Now, how about other studies? Well, when this has actually then subsequently been looked at in many other studies, including in non-Mediterranean countries, the effect has been somewhat smaller. So on average, the reduction is only about 10%. Now, there has been debate, is that the reduction less when you include non-Mediterranean countries because there's something specific about the terrain, like, is it something about the olive oil or something about the tomatoes or the vegetables, et cetera, that could be, different, or the lifestyle? It's hard to know, but definitely when you look at when you include other countries, The risks risk reduction is lower, but it's still there. It's about 10% on average. And again, this is for mortality, but it's also for CVD incidence, mortality, as well as cancer. I'm going to include some pictures, I hope you don't mind, of the Mediterranean. And this is a nice meal of the small fish as well as some vegetables there. Okay, now in terms of randomized trials, I showed you the observational data. So how about randomized trials? I'm a cardiologist, and in cardiology we love clinical trials. In fact, we love them so much we give them all acronyms that when we have sometimes the same acronym for like 10 studies because we're not very creative. But in the Lyon heart study was a clinical trial. This was conducted among about 600 men in France. These were post-MI, so they experienced their MI in the hospitals in Lyon, and then they were randomized to two types of diets. At the time that the study was started, the AHA Step 1 diet, which recommended about a 30% fat, that one actually was the recommended diet, so that's why they chose that as the control. And the comparator was the Mediterranean diet, and you can see here that even over a short period, even the curves start to separate really quickly in terms of survival, free of CHD death or recurrent MI. So there was a big drop, and for some of the endpoints, it reached as much as 70% for especially the sudden cardiac death. Now, these are some of the endpoints that they also looked at here. I showed you, so total death was reduced by about 56%, cardiac mortality by 65%, non-fatal MI by 70%. In particular, also sudden cardiac death was reduced by 7%, and cancer was reduced by 60%. Now, you can see the absolute numbers are small, so 7 versus 17 or 8 versus 25. So people said, well, it's a very small study, it's 600 men, they're all French, and maybe there's something different about the French. You know, we all know they sort of seem to, you know, eat everything and never gain weight and et cetera. So maybe there's something different about this patient population, you know. So people did not really believe this. And in fact, the AHA did not really change its guidelines to recognize this randomized clinical trial for these limitations. But let's review what they did in the Lyon diet heart study. What they increased is the increase of fruits and vegetables. The increase of vegetable oils as well, but the main oil was the alpha-linolenic oil. They also had increased EPA, DHA, beans, fiber. They still had cheese, you know, but they included also poultry and fish. What they decreased is they decreased the meats, the butter, the cream, the saturated fats. And what remained unchanged was really the total fat. In fact, in the Lyon heart study, the total fat was about 30 to 33%, but depending on the diet, the Mediterranean diet is sort of a moderate fat diet. It's not low fat, it's not high fat, it's sort of in the 30 to 40% range. And in fact, that may be one of the reasons why people can really maintain it, because long-term, that makes it easier to maintain. And in this study, trans fatty acids at that time were unchanged. Now, this is relevant because then subsequently there was another trial also conducted in a Mediterranean country. This time it was conducted in Spain, the PREDIMED study. And the PREDIMED study took patients who were high risk for CVD. So Lyon was patients who already experienced an MI. PREDIMED said, well, we'll test it in high-risk CVD. And the reason high risk was because they wanted events, right? So they couldn't take low risk because then it would be forever. And they took men and women who were 55 or 60 and older. And they had to have either type 2 diabetes or 3+ cardiovascular risk factors. So what were the 3+ cardiovascular risk factors? So they were smoking, hypertension, dyslipidemia, overweight, obesity was one of them, as well as family history. So keep that in mind for patients who have family history of early onset coronary disease. And they included about 7,500 participants, and they randomized them to 2 arms that were Mediterranean diet and 1 arm that was the control arm. The 2 arms that were the Mediterranean diet differed, and I'll talk about them a little bit, but they were really truly an intervention. They weren't just like advice to eat Mediterranean diet. They were truly like they brought them in, they had them see the nutritionist, they had individual as well as group counseling. So they really, and these are people in Spain who already are very familiar with like what's a Mediterranean diet, right? Because they're right there. So it was just about ways to improve adherence to the Mediterranean diet, as well as to incorporate the ingredients that they got into the diet. So what did they find? Well, the PREDIMED study found that there was about a 30% reduction, as shown here, in terms of CVD. This was a combined endpoint of cardiovascular disease, but was a hard endpoint, included MI, stroke, and CVD death. And both arms were very similar in terms of their benefit compared to the control diet. You can also see that the curves start to separate quite early. And as we know, for example, comparison, just to compare that, like statins that everybody gets, they usually, start to separate the curves after about year one, unless you're in the setting of acute coronary syndrome. So in this type of population, the event rates would separate in patients who go on statin after about a year, just to put that in context. So both arms work, the Mediterranean diet with the extra virgin olive oil, I'll refer to it as EVO from now on, or the Mediterranean diet with nuts. So let's look more closely at some of these endpoints. Well, what turned out, actually, before I go to the endpoints, in 2018, there was a big hoopla about this in the press, but basically it ended up being that there were some irregularities in the study, but that happens in any clinical trial. I mean, anybody who's been involved in any clinical trial knows there's going to be irregularities, right? That's why there's an IRB, because you always have to report your irregularities. So there were some things in terms of, in my opinion, there weren't really substantial irregularities, but, New England Journal and Lancet are very strict in terms of their guidelines. So they actually had the authors retract their paper and then republished it. But basically nothing changed. In fact, if anything, once they adjusted for those irregularities, the results got a little bit stronger. But basically, the idea is that the results did not change after the corrections. So just to keep that in mind, because this did get a lot of press in terms of the press release at the time. Now, to put that in comparison, so for PREDIMED, there was 30% reduction, relative risk reduction. So statins, in general, on average, result in about 20% relative risk reduction. Now, some studies show more, like 30%, or even up to 40%. But in general, statins, on average, show 20% relative risk reduction for CVD. So just keep that in mind. And statins don't always reduce mortality as well. Now, here's PREDIMED. What they did was the extra virgin olive oil, they gave them, again, not just advice, but it was really counseling on the Mediterranean diet, but they also gave them EVO about 1 gallon a month, right? Now, anybody here who uses olive oil knows that's that's a large amount, right? So what that boils down to is 4 tablespoons per day. Right, because they conducted the study in Spain, and they wanted to make sure that people had enough olive oil to cook in and have the family members also eat. So that's why they gave them 1 gallon a month. They gave them more than they needed per se for them personally, but they gave them also for the family members who were eating. Now, when we were in Journal Club, we reviewed this paper. One of my colleagues said, "But Samia, how on earth am I going to get 4 tablespoons of olive oil, extra virgin olive oil, in my diet?" And, he suggested maybe he should just drink it in the morning, But the whole idea of PREDIMED is actually they did not just drink it. I mean, it may have the same benefit, who knows? But what they did with it was they actually cooked with it vegetables, whether in salads, adding it on top of salad, not necessarily on top of bread, which is what, if in the US you just gave people a whole bunch of olive oil, most people will just add it to bread. But it was actually mostly added to vegetables, whether raw or cooked. In the Mediterranean diet with nuts, what they also got the counseling on the Mediterranean diet. And again, they brought them in, they had individual and group counseling, more intense initially, but continued throughout the study with nutritionists. So the really intensive dietary counseling as well on the Mediterranean diet. And they asked them to eat nuts. They actually provided them with these packages of nuts, walnuts, hazelnuts, and almonds. These were raw, they were not cooked. And they had about, the equivalent of about 3 whole walnuts, 8 hazelnuts, and 6 almonds per day. And they were asked to eat them before the evening meal, predominantly, I think, to help for satiety, because sometimes people gain weight if they're eating very late at night. So total was like 30 grams of raw nuts per day. And again, they were asked to maintain that throughout the period of the trial, which was 5 years. The control group, now PREDIMED has been criticized for the control group. And it's really hard to come up with a control group for a dietary or even other lifestyle interventions, because it's hard to not offer people anything whatsoever. But at the same time, if you offer them so much that then they're so close to the intervention group, the trial will end up not showing, necessarily a difference among the arms. So it's really always a hard challenge. But what they did was, they gave them advice on a low-fat diet. They told them to basically reduce their fat, because remember, the Mediterranean diet is a moderate fat diet. So they asked them to reduce their fat. They discouraged them from using nuts and olive oil. And after a couple of years into the trial, they started giving them these non-food items as well, the equivalent of about $30, $35 or so a month. So they did give them the equivalent of sort of financial equivalent, but it started later. They also came up with a 14-point, as I mentioned earlier, the Trocopoulos scale was from, the Greek studies. I mean, there are various scores that have been, devised to sort of capture the Mediterranean diet. In PREDIMED, their score, is sort of typical score, but it also included Sofrito as a point. So Sofrito sauce more than twice a week was also included. The things in red, they're supposed to decrease, and the things in green, they're supposed to increase, especially if they were in the extra virgin olive oil arm. So how about compliance? Well, compliance was actually quite good. On this 14-point scale, the control group had a compliance of about 9, and then with the Mediterranean diet, right? So keep that in mind. This is a group, again, in Spain, so they're going to have pretty good compliance even at baseline with the Mediterranean diet. So they had 9 out of 14 point was the average. You can see with time it increased a little bit. Again, they're part of a study. They know they're being followed. The Mediterranean diet group, both groups actually had now compliance of about 2 points higher than the control. So it was almost like an 11. So just keep that in mind, that the benefit that they saw in terms of reduction in clinical outcomes was based on a 2-point difference in the score. And that's, I think, a really key message to tell patients and to remind ourselves of it, that we don't have to be perfect. Like, it doesn't have to be 0 or 14, very few of us can do that. But if we can do just 2 points extra, then we may be able to see some of the benefits that we're seeing. And they maintained it. You can see that it's not like it dropped down, even though the counseling was less, after the first year. So they were able to maintain that 2-point difference. Now, you may ask, well, for comparison, what does, say, Mediterranean adherence to other non-lifestyle? For example, in this case, I got an example from the PURE study. PURE was a worldwide study actually conducted worldwide by Salim Youssef, and he looked at 4 drugs that are commonly prescribed for patients who have cardiovascular disease or are at high risk: aspirin, statins, beta blocker, ACE inhibitors, or angiotensin receptor blockers. And these 4 kind of what we call the bread and butter of cardiovascular disease prevention or treatment. You can see here worldwide, more than 50% of the patients in the PURE study, this is a very recent study published a few years ago, more than 50% were actually on none of these drugs, even though they actually already had cardiovascular disease. So adherence is really difficult. In terms of 3 or more drugs, you only had about 10 or 15% worldwide. Now, even in high-income countries, for example, the US or Canada, you can see that adherence to 3 or more of these standard established drugs is only about 50%. So again, we have this issue with adherence to medications, and I think this is where potentially, adherence to a diet that could be incorporated into one's lifestyle it has a role. So because Sofrito was part of the score, I figured I'll just mention it briefly because, many of us may be familiar with it, but may not know it's called Sofrito because you may do it as part of your cooking. So what it is this is the recipe, is tomato, onion, parsley, extra virgin olive oil, and you basically mince them all together and you put them slowly simmering in olive oil on the on the pot for a little bit, and then you add that sauce to whatever you're cooking, like vegetables or the protein or whatever, legumes, etc. So this is it. I mean, it's a simple thing. We often do it. It's often done around the Mediterranean. It's just people don't know necessarily that that's called Sofrito. So what were the differences in the Mediterranean diet arms compared to the control in PREDIMED? So this is what happened. So the Mediterranean diet plus Evo, of course, they increased their olive oil. They also decreased their sort of lower quality olive oil. By the way, the extra virgin olive oil in PREDIMED, about half of it, was sort of the same one that's sold in Whole Foods as the 360 olive oil. So it wasn't like necessarily the most expensive olive oil out there. Nuts, they, of course, because they're trying to separate the two arms of the Mediterranean diet. So the Mediterranean diet plus Evo, we're not supposed to take in nuts, but of course that increased in the other arm. Now, what both arms did is they both increased their intake of legumes, shown here, and they also both increased their intake of fish or seafood, as you can see here, compared to the control diet. So in addition to the nuts and the Evo, what they did in terms of practically is that they increased their seafood, fish, and they also increased their legume intake. So these were the key points of what actually changed. Now, here are some recipes. You can go online or look at their website for some of these recipes. But you can see a lot of them involve olive oil. You can cook with it as long as it doesn't burn. You basically use it at the low levels for sautéing, etc. And of course, like some of the other herbs and garlic, etc. in the food. These are going to make you all hungry, so I'll go through them pretty quickly. Okay, so in terms of what's healthy, so people have puzzled. So this Mediterranean diet seems great. So which component is it? Maybe we can just isolate that, and just give that maybe as a supplement. We all love supplements. Or you just pop them in. Again, how are you going to take that 4 tablespoons of olive oil? For me, it's not a problem, but for some people it is. So people have been debating what is it in the Mediterranean diet, and it's not really known. It depends on who you ask, and everybody gives you a different answer. Some people say, oh, it's for sure the alcohol, but then all these alcohol studies came out recently that suggest, well, maybe it's at least for stroke, it's not necessarily beneficial. So how about like the extra virgin olive oil? Well, the extra virgin olive oil, and what extra virgin means is basically it's the first squeeze of that olive, right? So olive is a fruit, and you're basically trying to get the first thing that comes out when you squeeze it. That's the extra virgin, and it should be cold pressed because heat affects the quality also of the oil. So they usually do it cold pressed. They used to do it in the old days with stones, but now they have more advanced machines to do that. So polyphenols have been thought to be the substance. And the darker the olive oil, the more green it is, the more bitter the olive, the more the polyphenols. And the more bland it tastes, the less of these polyphenols that you'll have. But walnuts and the other nuts also have polyphenols and other potential beneficial components shown here, of course, fiber and other fatty acids that are also beneficial. Now, there are also other benefits from the Mediterranean diet. In PREDIMED, they noticed a reduction in atrial fibrillation from the Evo arm, only from the Evo, not from the nut arm. The nut was non-significant, but the Evo had about a relative risk of 0.62 reduction. Now, it was among, it was sort of not a pre-specified endpoint. It was a post hoc analysis, and they found that. So keep that in mind. And they also found other things. For example, in some of their analyses, there was a suggestion that at least waist circumference was possibly reduced, in particular in the nut arm. I showed you the AFib data. There was also improvements in other things. Among the half the population or so that did not have diabetes at baseline, there was a reduction in incident diabetes. The Evo arm also had reduction in breast cancer, only the Evo, not the nut arm. And there was also improvement in sort of the prevention of the age-related neurocognitive decline. They did do some cognitive testing in a subset of the participants. And a lot of their biomarker papers showed various improvements in different biomarkers. I'll show some of them in the next few slides. So the question becomes, again, how does the Mediterranean diet prevent CVD and potentially other diseases? And so it's been postulated to have various mechanisms. What we do know is, for example, LDL cholesterol and total cholesterol is often not reduced with the diet. However, there are improvements in other aspects involving lipoproteins, including reductions in the oxidized LDL, which is necessary for atherogenesis. There's also been, some of their studies have suggested improvements in HDL function. But there are other pathways too, pathways relating to inflammation, pathways relating to metabolism, in particular some of the gut flora related metabolites may be improved. So there's a variety of pathways that could be involved. So what we set out to do, and most of this work was done by Dr. Shafqat Ahmed when he was here, as postdoc fellow between the Brigham and HSPH. He's now at Uppsala in Sweden. What we wanted to do was we wanted to examine the extent to which what we know about some of the risk factors for cardiovascular disease, how does that sort of fit in terms of the benefit of the Mediterranean diet on reducing CVD events. Because while we know the Mediterranean diet has these many effects, we don't know sort of what's the relative contribution of these different pathways to reducing the outcome, the clinical outcome of CVD. It's sort of a black box in terms of the mechanisms because you need a very long-term study, and clinical trials cannot really be conducted over a long-term study. So the only way to do this kind of analysis is really observational analysis. So this paper did get a lot of publicity, luckily, for people who are fans of the Mediterranean diet, and also, you know, of course, this is a good thing for increasing awareness among the population. So what we did do is we took about 26,000 women in the Women's Health Study. Now, the Women's Health Study started out as a clinical trial now almost 20 years ago, but the clinical trial primary endpoint was CVD and cancer, and it was a trial testing aspirin at low dose, vitamin E, and alpha tocopherol. So after about 10 years, the study continued as a follow-up study. The mean age of the women was about 55, but they were 45 years and older when they were enrolled. And we had various risk factors about them, and we did a diet score for them also, Mediterranean diet score based on the components. So these women were not told to eat diet in any specific way. They were just, this is what they were eating. And these women were healthcare professionals from the U.S., across the U.S. Mostly these were nurses, but also included other allied health and other physicians as well. So we created a score for the Mediterranean diet to assess how adherent they were at baseline. And we also had measured through various other studies, including like the Reynolds Foundation that had previously funded some of the inflammatory biomarkers, some of the NMR biomarkers that were funded by AHA and NIH. So we had a bunch of different biomarkers that were measured in the study as well on the baseline samples. And we wanted to see, well, what were the potential mediating mechanisms of benefit in terms of reduction for CVD? And was there even a reduction? Because in the US, you know, most of the studies that had examined this were usually on the average like a shorter duration studies, not over a longer period of time. So we wanted to see what were the potential, you know, mechanisms. And this is a summary actually also of the results that you'll see there were basically multiple mechanisms that contributed to the benefit. So what we found was that the women who were more adherent to a Mediterranean diet, who had a score of 6 or greater, and in our case, you know, 9 was sort of the highest you could get. So if they were 6 or greater, then they were considered to be adherent to the Mediterranean diet, and those women had about 25% reduction in incident cardiovascular events. So incident stroke, incident CVD, death, and incident coronary heart disease over a duration. In this case, we looked at it both at 12-year as well as the longer-term follow-up. We were able to explain with these various biomarkers and clinical risk factors about a third of the benefit of the diet. So about 2/3 of the benefit of the diet still we could not explain. And I think because, of course, you know, in our study we didn't measure everything, and these are areas I think for future investigation. But we were somewhat surprised to find that inflammation, insulin resistance, and body mass index were sort of like the top 3. That explained about 25 to 30% of the benefit. but also other factors such as improvements in blood pressure or blood lipids, in particular the HDL and VLDL. Remember, I told you LDL cholesterol is actually not reduced with the Mediterranean diet. When I put here LDL measures, that's really more LDL size and particle number. In fact, LDL cholesterol had zero relationship. But when you look at other aspects of LDL, such as the size of the particles, the number of particles, those were affected. And also branch chain amino acids, which have been related to insulin resistance, also were contributing. Now you can see that if you added all these up together, they're going to be more than 100%, but that's because these variables and risk factors are correlated. So when we show them this way one by one, we're not really showing the correlations. But when you take into account all the correlations, it's still about 30 or 35% that we were able to explain. Now, what's known about the anti-inflammatory properties of the Mediterranean diet? Well, this topic has been the subject of investigations of prior studies. And I wanted to highlight this one study in particular, because this was a clinical trial. And this was done by Iris Shai and colleagues in Israel. It was done actually in the Negev Desert. And the participants in this study were employees at a company. And so they were sort of, the only access to food was whatever was in the cafeteria. Now, they did get consent, but they did randomize them to 3 different arms, a low-fat arm, a Mediterranean diet arm, and a low-carb arm. Now, the Mediterranean diet and the low-fat arm were actually energy restricted. The low-carb arm was not energy restricted. And their main interest in this study was to see what happened to weight. They wanted to see does any of these diets reduce weight, and they followed them. The primary publication followed them for up to 2 years, 24 months, and what they found was that there was initially a reduction in weight here shown by kilograms on the y-axis. On average, at the end of the study, the weight reductions among the arms was between anywhere from like -3 kilograms to -5 kilograms after 2 years. And again, these people were given the diets. Basically, that's all they ate for the duration of the study. And the energy restriction was incorporated in that when they got their meals, when they were randomized. So you can see here, but what you can see is the Mediterranean diet, which is in orange, was very close to the low-carb diet, and both were significant statistically compared to the low-fat diet shown in red. Now you may ask, well, what happened in terms of other biomarkers? Because they also measured other biomarkers that were measured on the blood samples of these participants. And what you can see here, for example, I'm showing here C-reactive protein, a marker of inflammation. You can see there was a reduction in the C-reactive protein, keeping in mind that these people were overweight to start with, so you may see more reduction compared to a general population. But there were reductions in the order of about 0.5 to 1 milligram per liter in C-reactive protein. But this was the reduction in CRP was significant only really in these 2 arms, the ones that were the Mediterranean and the low carb diet. Now, it turns out of the 3 diets, only the Mediterranean diet arm of these 3 in this study improved insulin resistance. The other 2 did not improve insulin resistance. So the Mediterranean diet, improved both inflammation and insulin resistance compared to our consistent with our study findings. And then what they did is they published a follow-up in a letter to New England Journal a few years later, because 24 months was the dietary intervention period where they were actively given the diet, et cetera. But then the follow-up was, now they're just eating whatever they can eat or they want to eat. And you can see here that the weight, in terms of the weight, the Mediterranean diet and low carb remained significant compared to their baseline, but the Mediterranean seemed to have the best, the most favorable maintenance of prevention of weight gain again, so that there was about a 3 kilogram weight loss. All right, so now I'm told I only have a few minutes left, so I just want to show you some insightful data. Basically, the HDL lipidome in this study that's been submitted by one of my colleagues, Siskovic, the HDL lipidome completely remodels, and these individuals, this is a four-week period where the same individuals were given a fast food diet or a Mediterranean diet. The same people, you can see huge changes in their HDL lipidome. There's other effects of the Mediterranean diet in terms of the metabolism, the gut microbiome. There's effects on both the type of gut bacteria present, as well as some of their effects. TMAO has been identified by Stan Hazen and others as a potential risk factor for cardiovascular disease. And one of the components, the DMB, the 3,3-dimethyl-1-butanol, which I can never remember, but that is a component that actually is produced by some of the good bacteria, and that actually is also found in olive oil. So, whether or not that's related to also benefit, that could be part of it. Now, just finally, the Lancet recently commissioned this EAT commission that we discussed in Journal Club, and what they suggested is that if one serving a day is replaced with other protein sources, shown here, for example, low-fat dairy, nuts, fish, or poultry, in particular nuts, you can see there could be up to 30% reductions in CHD, stroke, diabetes, and all-cause mortality. And how are we doing? Well, the Global Burden of Disease study recently also published this, and you can see that the line here is what we should be doing, and above it is not good for red meat and starchy vegetables. So you can see we're above for red meat, starchy vegetables, eggs, in some countries for poultry as well. But we're under for fish, vegetables, fruits, legumes, whole grains, and look at nuts. I mean, really at the very bottom there. So unfortunately, we have to all sort of fight this sort of transition that's affecting global health. And then finally, just to remind us that adherence to a healthy lifestyle matters, whether you have genetics that put you at increased risk for CVD or whether you don't have those. In terms of the relative risk reductions, they're similar, but the absolute risk reductions are even greater in people who have genetic polymorphisms that put them at increased risk. So take-home messages are that lifestyle interventions should really underlie all of our preventive efforts. I hope I've convinced you that the Mediterranean diet is a beneficial dietary pattern that has many health patterns, and even a 2-point increase in adherence and better adherence to the diet has reductions in cardiovascular disease that are similar to statin benefits or other medications known to prevent cardiovascular disease. And so I think the main public health message is that even modest changes in our diet, which affects these cardiovascular risk factors in multiple ways, has really important consequences long-term for reducing cardiovascular events as well as other outcomes. And I just want to thank the other people in my group who've worked with me and contributed to the data. So thank you, and I'm happy to answer any questions.
Well, that was really fabulous. Thank you so much, Dr. Mora. I think we have time for questions. Maybe we can start here in the audience using the microphone, and then we'll go back and forth to some of the Slido questions.
I have two questions. One is, what do the Mediterranean diet have to say about the new rage, of course, which is keto, which is very low carb and very high healthy fat? And the other question is, how do we guard against fake olive oils? How do we know our EvoCan really is what it says it is?
Right, yeah. Well, the second question is harder. I think the Evo, so the quality of the Evo. Well, I mean, there's good news and bad news, right? Bad news is that really good olive oil is expensive. It's not cheap. But the good news is that, like, the PREDIMED study used an olive oil that was not very expensive in terms of, you can buy it from sort of a supermarket. I mean, it depends on, but it's not like the higher end. It's sort of like in the middle range of they used a few different ones, but the one that they got was basically the whole, I mean, I don't want to make advertisement for anybody in particular, but I'm just, it was the Whole Foods, like 360, similar to that one. But basically, the bottom line is a lot of the olive oils that you get from the supermarket that look dark green, I mean, you can look at them. Once you get them, also, they should be stored in a cool, dark place because also light affects them. But if they're dark, in general, they're better. So as opposed to the lighter ones that look more like, other oils. Now, in terms of how to know if it's pure, well, I can tell you firsthand, my mom has had difficulty getting her olives. She picks her olives. That's why olive oil is expensive, because you have to pick mostly hand-picked. Now, there are machines. Some places use machines, but mostly these are hand-picked olives. And then what happens is you only get certain amount of oil from the olives. You have to pick a lot of olives to get a certain amount of oil. And the issue is that because it's so expensive, people often dilute it. They may even dilute it in the factory that you take your olives to. So even if you take your olives, sometimes you can still get cheated. But some people say, well, if you put it in the refrigerator and it freezes, it sort of solidifies, that means it's more pure. So that's one way you could test it. The other thing is it's not supposed to be really, it's supposed to have bitter polyphenols. It's not really supposed to be very acidic. So if there's a lot of acidity when you're tasting it, also that could suggest that it may be mixed with some other olives. But if you really wanted to, you could test the chemical components of your olive oil. But I would say the rough sort of, thing is if it looks darker and, the ones that are sold in most of the supermarkets, at least the well-known supermarkets in the U.S. should be, the label should be consistent, at least with what they're selling. In terms of the ketones, well, I mean, the advantages of the Mediterranean diet compared to sort of a ketogenic diet is that it's very, as I showed you, the adherence did not drop off. Now, that was in a clinical trial, but it's much, long-term adherence to it is better. It's the only one that was shown to show improvements in insulin resistance, as I showed you. And it also reduces inflammation. So, and it's very easy to, it's the most, people can really maintain it because it includes a lot of variety, because we really love variety. And some people may like nuts, but other people may like, chickpeas, and other people may like, fish or whatever. So you can, mix and match. And so I think for patients, once they sort of know how to use the ingredients, et cetera, then I think it's sort of easier to maintain long-term, and it's the only trial that's been tested that has reduction in cardiovascular events. I mean, the other ones have not. We do not have any, in fact, they change risk factors in some ways that may increase cardiovascular disease.
We have a question from one of our online people that's also a comparative effectiveness question, which is, are there any studies or research comparing purely plant-based diets to the Mediterranean diet in terms of health benefits?
Yeah, so I got asked that question a lot. In fact, I have one of my friends, Rob Osfeld at Montefiore, who's a wonderful cardiologist, preventive cardiologist, and he's a big fan of now, just keep in mind first, the Mediterranean diet is mostly plant-based. So it's not purely plant-based, but it's mostly plant-based. Now, if you wanted to do it entirely plant-based, you could do that, right? So Rob, when he saw the paper come out, he texted me right away. He's like, Samia, so, would you see the same effects in the women's health study that, great paper, thank you so much. But would you see the same effects if you did not include if you did it purely plant-based? So we actually did that analysis, and we didn't find as much the benefit. So we plan to publish that because I think that is an important finding. But I think the key message is really trying, it really is a plant-based diet. It may not be strictly, 100%, but it really is predominantly plant-based diet.
Any other questions?
Yeah.
Hello. Thank you for such an interesting talk. I'm not a paid scientist, so I'm just a regular person, and I'm just wondering about what you would say. I would say my takeaway seems to be weight loss helps, and that perhaps this particular diet works because it's tasty, and it's easy to maintain because it tastes good. What do you think?
I think you should have given the talk. Yes, that is the take-home message, exactly. In terms of the weight issue, it's a little bit complex. So what we do know is that people who adhere to this type of diet, generally over time as they age, have less of the age-related weight gain. In terms of the PREDIMED study itself, they did analyze the weight changes in the PREDIMED study. In fact, they had to republish them, like I said, because Lancet also forced them to republish their data. So it's sort of, again, these were sort of people enrolled in a clinical trial, and there were small reductions in terms of BMI and waist circumference. There weren't like whopping differences compared to the control group. But again, keep in mind the control group had an average adherence to the Mediterranean diet of about 9 points during the study. So, but I do think from the other data, the non-randomized sort of more observational long-term data, we know short-term it causes, weight loss, especially if you energy restrict. The issue is, if you maintain adherence to it long-term, we do know that the people who do that, they do have less weight gain. But it is very tasty, and in particular because it includes all these components, it may take an extra effort for us to teach people or for people to inform themselves of how to use these various components in a way. In some places like food deserts, they may not have access to fresh fruits and vegetables, but they could potentially use more frozen fruits and vegetables or legumes that then they can process. I'm also not a big fan of processed legumes that are sold in cans with a lot of processed salt, et cetera, in them. But yeah, we have to be creative, and I think all of us have to sort of come up with better ways that this can be incorporated into a typical American diet from various regions in the U.S.
Another question from our Slido virtual community. So this obviously requires behavioral change and education, but what would the challenges be, or would there be unique challenges for populations of lower socioeconomic status in terms of costs of, at least in this country, not where access to fresh fruits and vegetables are readily available in the Mediterranean?
Right. So I think that's an important thing. I think there are several challenges. One is, the extra virgin olive oil is not cheap. While it's not maybe super expensive, you can buy the sort of medium level, but even that is not cheap. So could there be some subsidies that, that could be obtained for that specifically? The other challenge is actually just even availability. I mean, I did my fellowship at Hopkins in Baltimore, and, in downtown Baltimore, I mean, you go to the supermarket, there's like no fresh fruits and vegetables. I mean, they're all like wasted, I mean, you could not even like eat the stuff, even if and it would still cost the same as if you bought it in like, say, Columbia and Maryland or whatever. It just was unedible. So I think, but I think there's ways around that. So there are frozen fruits and vegetables. You can get those. They seem to have just as much benefit. Or at least a good amount of benefit. There's also been sort of the issue are you getting some of that benefit because then you're eating less of the red meat, less of the processed meats. We know processed meats and red meats are really detrimental. So is it because you're really sort of eating less of those? But I think the challenges are in terms of cost, and I think like other lifestyle behaviors, it is a lifestyle. And people have to, know how to mix these ingredients together. Even if you gave people olive oil, if the only way they know how to eat it is, say, on bread, then that's not going to have the benefit, because it's really about how do you incorporate it into cooking the vegetables, into adding it to salads, to be creative. But I think that another one is the nuts. Like nuts are easier, I think, because most people, you don't have to do anything to the nuts. You just eat them, right? As long as you get the right nuts, you don't get the ones loaded with sugar and fat and bad fats. But the nuts are also, not cheap. So I think cost is an issue. So we have to keep that in mind. But in terms of overall health savings, if we can prevent cardiovascular disease, obesity, diabetes, all the complications that are related to that, I think it would be really cost effective overall. But the challenges are how to incorporate that. Now, luckily, the U.S. Dietary guidelines do recommend now Mediterranean diet as one of the 3 healthy diets to recommend. And luckily now the AHA recommends it as opposed to, so we've turned around. So I think at least that's the first step. We tried our best to convince NIH, NHLBI to fund us for a large clinical trial for Mediterranean diet to kind of address some of these challenges. But unfortunately, they weren't ready for a large trial. And it's hard to do, large trials without money. And so I think that's another challenge from research perspective.
Maybe one more quick question.
Ivana Holland, I am a visiting scientist from Norway. And so when you were asking about who is eating Mediterranean diets, for me it was a little bit difficult to reply, because for me, like, the Mediterranean diet, it has so many components, like the real one. So the presentation of the trials, it's very clarifying, because you know what they get. But when we Norwegian people get to Italy, we get very surprised how much white bread they eat, or baguettes, or that we get sweets for breakfast. In Norway, it's just, we don't do that. We have to eat whole grains.
Yeah.
So I am wondering, like, we are always thinking garlic and olive oil, but these things surprise me. So I wonder if there is something so protective, as you say, like against insulin resistance and like protective demetabolism, so that they tolerate in a better way some of the things that we considered.
Yeah, I mean, it is. So yes, thank you for your comment and question. Actually, I congratulate Norway for changing their diet as well. More and other Northern European countries have changed their diet more towards Mediterranean. So yes, you are right. I mean, that is one of the key points. Is when you do go to Mediterranean country now, unless you're going to a very traditional area that's kind of more isolated, you know, the effect of the westernized, you know, the McDonald's almost everywhere, the Burger Kings, and so it's difficult, and even the bread, the quality of the bread has changed over time. So yes, when we're really talking Mediterranean, we're talking traditional, really traditional concepts. But yes, the other part of your question is, are there components of it that you know, and I think that is an emerging area of research, especially for the gut microbiome. I mean, you know, we do know that that is very, you know, versatile, and many things can affect it. And it is possible that, you know, some components are protecting you. So even if you're eating some of the non-Mediterranean diet, you know, sort of less healthy food components, that you may be able to tolerate it better. But in general, as I showed you, because in PREDIMED it was a trial. And so in that trial, on a background of Mediterranean diet, those who adhered more, and even 2-point difference, had benefits. So I think that's the key, is sort of how can we, each of us, do that on an individual level, and how can we spread the word to others, and encourage that kind of pattern. Yeah. Well, thank you all very much, and I really appreciate you being here.
Well, that was really fantastic. It's about as good as it can get. Rich information, lots of evidence, and just lovely pictures of the Mediterranean. So thank you all for coming. A couple of quick announcements as we head out. If you didn't sign in on the way in, please do sign in. It's really important for us to document who's here and to keep track of how we're doing and reaching the audiences we want to include in these discussions. Same for you online. If you watch this and you're interested, please go to oshercenter.org and register. Couple upcoming events. Next month we have a really unusual ground rounds. Atra and myself and a couple other scientists from the Harvard community are going to explore this sort of provocative edge of what do integrative medicine and global climate change have in common. So there's some really interesting things about the footprint of hospitals on global carbon budgets and movements towards low carbon happiness and all sorts of other interesting phrases that we just want to bring to an initial discussion. So we hope you can join us for that. Also, the following month, in August, for those of you interested in nutrition, Dr. Kimberly Parks is going to lead one of our studies, our grand rounds on culinary medicine. So we'll continue this discussion about behavioral changes through diet and health. And then finally, particularly for those of you in the traditional Chinese medicine and acupuncture community, Osher is co-sponsoring a really landmark event, I believe it's going to be in Burlington, Vermont, on June 27th to 29th. It's in partnership with the Society for Acupuncture Research. And it's a multiple stakeholder event. It's funded by NIH and PCORI, and it's bringing in representatives from healthcare providers, Blue Cross, Blue Shield, the Veterans Administration, Department of Defense, as well as the scientists to talk about the future of acupuncture integrating into healthcare system. So it's going to be a really nice event. So thank you again for coming. Please join us to continue this discussion. Probably not Mediterranean food out there, but there's a little fruit and some fruit and vegetables. Stay away from the sticky carbs. But thanks again, and hope to see you guys next month. And thank you again to Dr. Mora, of course.